Good evening and welcome to Doctors on Call. What would you like to know about annual exams, abnormal bleeding, osteoporosis, breast cancer, and ovarian cancer? I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm your host for our program tonight on women's health. We'll be happy to answer your questions. Just call locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome our panelists this evening, Dr. Jennifer Boyle, an obstetrics and gynecology specialist with St. Luke's Obstetrics and Gynecology Associates in Duluth, Dr. Brianne Brandt-Griffith, an obstetrics and gynecology specialist with Essentia Health-Duluth Clinic in Duluth, and Dr. Addie Licari, a family medicine physician with the St. Luke's P.S. Rudie Medical Clinic in Duluth. We also have a great group of medical school volunteers answering our phones tonight, including Paula Gusfridi, Amanda Hagan, and Linda Liskowitz. I also want to thank Dr. Ruth Wester for switching programs with us so that I can be out of town next week, and appreciate, again, your willingness to tune in and enjoy this program. Now on to tonight's program about women's health. Dr. Boyle, we had talked earlier about the new pap smear guidelines, and I wonder if you could kind of just bring us up to date where we should be as far as pap smear guidelines.
Yeah, a few years ago, about a year and a half ago, new guidelines came out. In the past, I think people will kind of remember, oh, every year I need a pap smear, every year. And now that has changed because what we were finding is that we were doing probably too many pap smears, which sometimes had abnormal results and then would lead to other procedures and things that maybe didn't need to be done. So now the guidelines, one of the major differences is that we do not start pap smear screening until the patient is 21. So that doesn't matter what their sexual activity is or any other factors really, just at 21 that's when we start. And then in the 20s we only screen every 3 years if it's normal. And then after age 30, what we will usually do is test not only for the pap smear, but also for HPV, which is the human papillomavirus. And that is what causes almost all the cases of cervical cancer, which is what we're screening for in the first place. So when we test for those both together, if they're normal, then we can do the screening again in 5 years. So this is a really big change for people who are used to having a pap smear every year. But I want to point out that that doesn't mean you can stay away from your doctor's office for 5 years. You still should come in for a breast and pelvic exam, check your blood pressure, and talk about preventive medicine things, but you just don't need that pap smear screening as often. And then if everything's been normal, then at age 65 is when we stop screening.
Very good. Dr. Brandt-Griffith, what about the new guidelines for breast evaluation?
Well, there's a lot of controversy surrounding breast guidelines as well as breast cancer, what the screening should be. The American College of OBGYN, or American College of OBGYN, says that right now the screening should start at the age of 40 if you have no prior family history of breast cancer, and then that screening should happen every year with a mammogram. The United States Preventative Task Force, however, did a retrospective analysis on women, breast cancer, when the majority of women were getting breast cancer, what the outcomes were if treatment was started at the age of 40 versus starting it at the age of 50. And what they found was that there's good data supporting that you can start mammograms at the age of 50 and have those mammograms every 1 to 2 years. And this does not include women who have a family history of breast cancer, who have any history of breast disease in their family at all or for themselves. Right now, because the data is a little, like I said, there's controversy surrounding it, that we're sticking with the guidelines that start at the age of 40. A lot of women develop cancer in their 40s or earlier, breast cancer, and so some of the obstetricians as well as family practice and internal medicine doctors that are out there feel uncomfortable with the fact that we would not be screening until the age of 50, given a lot of women who develop this cancer in their 40s. So I do think that it's a discussion that you can have with your physician. I think that if you don't have a lot of, like we talked about, risk factors or family history of breast cancer, then you can have a conversation with your physician about what the best time to start screening is. If you do have a family history of breast cancer, say it's a mother or grandmother or aunt or cousin, somebody who's a first blood relative, you want to start that screening approximately 10 years prior to when they develop their breast cancer. So if your mother developed breast cancer at the age of 40, you want to start screening around the age of 30. And then people probably have questions about BRCA, the genetic testing for breast cancer. And this is not routine testing for everyone. This is if you have a strong family history of breast cancer, ovarian cancer, colon cancer, that relative who had the cancer would primarily be tested. And if they were positive, then it could trickle down to the rest of the family members, whether they chose to be tested or not.
Great summary. It's really gotten confusing the last few years. Appreciate that a lot. Dr. Licari, there's several questions that come to mind as I listen to the new guidelines and then think about taking care of people as they get older. One of which is the osteoporosis piece. You're a family physician. Maybe you could talk a little bit about osteoporosis, and maybe there's other things that we should be thinking about on a yearly or otherwise basis in our patients as they get older too.
Certainly osteoporosis is a concern above the age of 65, and there are also things before that age that put people at risk for osteoporosis. People who smoke, certain people who take medications such as steroids, other family history risk factors, a mother or a sister with osteoporosis. So when we screen for osteoporosis, we order what's called a DEXA scan, or what you might consider a bone scan. We used to do these quite frequently. Back in the 80s and 90s, when we didn't know as much about how often to be doing these studies. It essentially gives us a score that is how strong the bone is, or what is the thickness of the bone compared to sort of a normal population. Based on that score, which is often called a T-score, we can then assign you as osteoporosis or osteopenia, which is sort of pre-osteoporosis. There are other things that contribute to osteoporosis aside from those risk factors. One of them is vitamin D status. And in this area where we get very little sunlight, vitamin D is probably more important than in warmer populations. So I tend, and a lot of practitioners around here tend to screen women at risk starting at age 50 for osteoporosis, and then consider universally screening people at age 65 for osteoporosis. If your testing is normal, we often will do a follow-up scan for general screening in at least 10, if not 15 years from that time. If you have osteoporosis, we consider checking vitamin D status to see if you're adequate. We also consider starting medications that as a class are called bisphosphonates, the most common one being Fosamax. And those medications are meant to preserve bone loss. They do not necessarily build bone, and they certainly come with risk factors with risks, as do all medications. So that's a conversation that you have with your doctor at the time of finding out your DEXA scan is abnormal or that you have osteoporosis.
So one of the questions is a lady that's having a parathyroid gland removed, and her question is, how can she rebuild her bone? And I think you've probably answered that as best you can.
You know, a lot of the studies have even said that starting at age 30, we start to lose bone. And so women are continually losing bone, you know, from that age on.
I try to tell my younger patients, you need to put it in the bank now, because after 30, you're just going to be losing bone no matter what you do. So you need to have good calcium intake throughout your life, but definitely in your teens and 20s. And I think that's something that younger girls and women need to hear, because you know, maybe they're not making the best choices for their food and drinks.
And really interesting thing about that is we've been pushing patients in the past to increase their calcium intake by using pills or supplements over the counter. And they've actually shown in recent studies that too much calcium can be a heart risk, a heart disease risk, or a cardiac risk. And so they're actually saying that you need to increase that calcium in your diet. You need to increase milk and cheese and yogurts and, you know, fortified cereals or orange juice, and start weight-bearing exercises when you're younger. That includes lifting weights and, you know, even your Pilates, yoga type of exercises.
The best picture of osteoporosis I've seen is a young teenage female drinking soda pop, and what that can do to the
And I think it's
bone.
important because, you know, yes, breast cancer is deadly, but this is very debilitating. You know, if you get a hip fracture, you may be in a wheelchair or a nursing home, and that is a really hard, you know, way to live your life.
And correct me if I'm wrong, but statistics show that after a hip fracture in an elderly woman, the lifespan greatly reduces after that.
Yeah.
Isn't it about a 1/3 risk of passing away that next year, something like that?
Yeah, and
It's pretty high.
And speaking of the parathyroidectomy, the endocrinologist sort of managing the follow-up care of that typically does do routine bone screening along with that.
So a person hasn't had a mammogram for 20 years, and the concern is the bruising and the pain and everything else. Are there other options to mammograms, and when should they be used?
There are other options. You know, typically in younger women who have very dense breasts, mammograms aren't going to be able to see the tissue as well, so they might use an ultrasound to examine the breasts. Women at high risk for breast cancer, these are your BRCA positive women, these are your high genetic risk women. A good screen, or what they recommend, is an MRI. However, this is not a good screening tool for all women because it's too sensitive and may lead to inappropriate biopsies as well as breast surgeries because of finding these microscopic little lesions, which turn out to be, you know, typically they turn out to be nothing if you're over screening. So mammogram has really been proven to be the most effective screening tool out there. Not a diagnostic tool, but screening tool for low risk women.
And I have had a couple of patients do some sort of alternative testing with thermal scanning, and that really is sort of on the experimental realm right now. And so there's no data to support other additional imaging techniques for screening.
Jennifer, there's a question that comes in regarding with the new guidelines, you're doing less examinations, you're not doing pelvic examinations, or you might not be. I think the guidelines that we get from the Academy of Family Physicians are a little less rigorous than what OBGYN goes by at the present time. So a lady coming in her 70s, her concern is that she's going to live longer. And I can remember an elderly female, when I wanted to sit on an abdominal pain one day and just watch it, her comment to me was a little bit knife-like, suggesting that I was neglecting her because of her age. So the question that comes up really is, what kind of exams should continue, and should these exams still be done?
Well, I think that's a great question, and we were talking about this before, that, you know, if you look at the studies, you know, is a pelvic exam really going to pick up ovarian cancer or something that we're, you know, screening for? But I think, again, it comes back to that, you know, you're coming into the physician's office, you're getting your blood pressure checked, your weight checked, somebody's talking to you about your smoking. So all of those things are good too. And I think even though maybe we're not doing a pap smear, maybe the patient isn't sexually active anymore, so, you know, she's not really having any concerns, but still you can get skin cancer, you can have vulvar cancer, and those are places you can't see yourself. So if you're not, you know, actively looking with a mirror, this is a time when somebody can screen for that. And so I think that there's still, you know, I think we've, as physicians, have gotten away from actually using our hands and putting them on the patient. And so now we're just doing, you know, tests and imaging and things like that. But we really need to still do a physical exam, you know, maybe not as often as we did before, but I think it's still valuable.
And I think the important thing is that you are having a conversation with patients, and we ask questions that somebody might think is normal. You know, we ask about incontinence, we ask about sexual health, we ask, even if you're 70, I ask you, how is your sex life? Is it painful? You know, how can we make that better? I ask about leakage of urine. I ask about bowel movements. Like, I ask these questions that some women are like, nobody's ever asked me that before. And I didn't realize that I had to live with this. So I think that's a great utility in seeing your physician every year as well.
Yeah, I've had several patients who have seen male providers before who didn't necessarily feel comfortable bringing up some of these things. And when you ask, have you had bleeding? Oh yes, I've had bleeding, you know, since age 50. And we do find things when we ask questions.
Very true. Hot flashes. So the question really is, this is a lady who has had breast cancer some years ago. Is there anything new and safe that she can take for hot flashes? Nothing has worked in the past. And of course, even beyond that, I would say that would have to do with other cancers and just with normal menopausal changes. So who wants to lead off?
Well, we have, you know, traditionally our best line defense for these vasomotor symptoms or the hot flashes and things was estrogen. But in patients who don't want to take estrogen, or they're afraid of it, or they have a cancer risk, we have tried, it's actually an antidepressant, and now they've marketed another one that is a little bit lower dose, same kind of drug, and people have had really good results with that too. And I think they're happy because it's a non-hormonal method. But I also talk to patients that it's usually self-limited. You're probably not going to have hot flashes forever, and you know, eventually they'll go away, and you can do things like avoid triggers, dress in layers, have a fan, you know, things like that, and you know, hopefully it'll go away.
They even make like mattresses and mattress pads that are cooling.
Oh, I did not know that.
Yes.
Because often it happens at night.
Right.
And then their sleep is all disturbed, which is then makes them crabby.
And their sleep partners probably too.
Yeah, exactly.
I mean, those are the other symptoms of menopause is insomnia, which can actually provoke some of those hot flashes. So if you can help your, you know, female patients sleep at night, some of those, most women tell me I can deal with it during the day. It's at night that it's disturbing me and I'm not able to sleep. And so if we can help make that or improve their sleep or quality of sleep, then it might improve the daytime as well.
And there are some lifestyle things that you can do for your hot flashes too. If you are overweight, you honestly insulate yourself a bit more than what someone else who is thinner may. And so regular exercise, losing weight if you need to, can help with that as well. Some women do find that certain triggers, such as high caffeine or high stress, can influence their hot flashes.
And the weight loss is good for the knees and
Yes.
good for a whole lot of
Everything
things.
else, yeah.
Questions come up a couple of times about cervical cancer and uterine cancer. Can having intercourse have any adverse effect on the male in someone who has cervical cancer or uterine cancer? And vice versa.
Well, I mean,
Well-
they're sort of they're the vectors of disease, the males are. So they, you know.
So as long as you're going down that road, why
Yeah.
don't you just expound on
Yes.
that?
So this cervical cancer is almost always caused, like I said, by HPV, and that is a
That is-
sexually transmitted
And
infection.
that's called what?
Human papillomavirus.
Thank you.
And so that's kind of where that all comes from. But really, if someone has endometrial cancer, I don't know what the question is exactly. You know, are they asking if after treatment, which would be a hysterectomy, how is sex different? And I think those are real questions. I do have a couple patients that, you know, it was just very, very painful afterwards. And there are things that we can do to help, you know, stretch the vagina and help intercourse not be so uncomfortable.
So let's talk more about HPV because I think that should come out. Addie, it's your area in some ways.
Well, HPV is sort of this thing that has been around. We've associated it with warts everywhere. I mean, hands, feet, all are forms of the HPV virus. And so in doing studies of cervical cancer and of genital warts, we found that there are several high-risk strains of the hundreds out there that do lead to either genital warts or high risk of cervical cancer. They seem to be more provoking of abnormal cells, seem to be more virulent. There's some estimates in the past that 25 to 50% of people have had HPV virus at some point in their lives. If you are young and sexually active, you likely have been in contact at some point. But young, healthy people who do not smoke tend to be pretty robust with their immune system and be able to sort of clear the virus much as you would a plantar wart. on your foot after a period of time. It's people who smoke, who have poor immune status, or people who are older, who are at higher risk for keeping that HPV virus around. The virus replicates in cells and causes abnormal cells to sort of replicate, and we all know that cancer is abnormal cells that continue to replicate on their own.
I think one thing to tell our viewers is that there are multiple stages before you get to cervical cancer. So there are abnormal cells, there's low grade, there's high grade, and then there's cancer. So we're doing pap smears so we can catch them at those stages that are below the diagnosis of cervical cancer. And if you can catch it below the stage of cervical cancer, the treatment is pretty minimal and curative. And so that's why we screen, that's why we do pap smears. Now the reason that the guidelines have spaced out that screening is because this virus is very slow growing. And a majority of women will clear this virus much as we said, clearing a plantar wart. So that's why the spacing has increased. And that's why some of even if you get an abnormal result, it may not prompt further investigation until another pap smear has proven that result. And so I think a lot of women get these abnormal cells and are worried that they have cervical cancer. And that's not exactly the case at that point.
Jennifer, you took a shot at the vectors. Tell us more.
Well, as we've said, HPV is another sexually transmitted infection. And now we have a vaccine that protects against several different types or strains of this virus, 2 that cause almost 80% of the cervical cancers and 2 that cause genital warts. And it's recommended for all, it was recommended for all women ages 9 to 26. And now Addie, help me, is it men too? Same age?
And boys in the
yep.
same age group.
Same age group.
So you're doing it to the boys? Are
yep.
they getting
We are
it?
offering it, yes.
Are they taking it?
What I would say is that half of all patients or parents will take the vaccine, and there are a lot of questions about this because it is a new vaccine, and there are some questions about whether it sort of takes those high-risk viruses out of the picture but then promotes the other viruses or the other higher risk viruses, and we just don't know. It is newer, but it does help prevent HPV.
Little change in direction. 77-year-old person, female. Is it normal to pass blood like a period monthly?
No.
Absolutely not.
No.
It is cancer until proven otherwise.
She should?
That's what we say.
She should be evaluated.
I mean, I say that kind of flippantly, but honestly, that it needs to be evaluated. And if it, you know, it could be a polyp or something benign, but I just had an 87-year-old woman who said, I just had a period. And it turned out to be a benign lesion, but obviously it needed to be worked up. And
if you have not had bleeding in a year, you're considered menopausal. And any bleeding after that year is considered abnormal and should be evaluated.
Yep.
Question regarding mesh templates. I guess I would direct it to the two of you. She's had it done, is incontinent again. What would you advise?
Well, I'm not sure exactly what kind of surgery she had. I think she should either see the provider who did the original surgery or get a second opinion, but probably she needs to be evaluated. You know, unfortunately, some of the surgeries, well, almost all the surgery we can say is not 100% successful. And I usually tell people with I think she's probably talking about an incontinence sling, that it's an 80% success rate. But, you know, certainly there's going to be some failure in that.
And once again, incontinence is very dependent on weight, again, on other comorbidities like chronic cough, chronic constipation, things that you might be able to treat. And there's different types of incontinence. Right. So the mesh or the sling may be working well for her, but she may have incontinence in a different aspect, and so that needs to be reevaluated. There are other surgeries, there are other options for her, but she definitely needs to be reevaluated.
Sometimes the bladder muscle itself will spasm. So even though you fixed the part where it was, I'm leaking because I cough, then they have this. And so it can kind of be both things at once.
The other thing that can make you have incontinence is a urinary tract infection. So that should be evaluated as well.
81-year-old female with implants, should she have a mammogram?
That's a good question.
Should an 81-year-old have a mammogram?
Exactly.
Yes.
That's what I was going to say.
Yes.
I think the guidelines, again, are a little fuzzy on when you should stop mammography because as you get older, your risk is still going up. It's my understanding. So
What I am talking with my patients about typically is that if you are in good health and you would treat a breast cancer, if we found a breast cancer, I do think that it's worth continuing screening mammograms. If you would not treat a breast cancer, if it were diagnosed, I would not continue with mammograms.
Very good. I want to thank our panelists. This has been a great discussion this evening. Dr. Jennifer Boyle, Dr. Brianne Brandt-Griffith, and Dr. Addie Licari, as well as our medical school volunteers, Paula Gusfriedi, Amanda Hagan, and Linda Liskowitz. And don't feel left out, guys. Next week, join Dr. Ruth Westra as we make our switch for our program on men's health, when her panelists will be Dr. Nicholas Johnson, Dr. Ryan Novak, and Dr. Eric Sather. Thank you again for watching tonight. Great questions. Have a great night.